All right, guys, welcome to the Digital Barbell podcast. Thanks as always for taking your time to be here. We've got a special episode for you today. We've got an interview with one of our clients, Michael White, who also happens to be a physician assistant up in Arlington, specializing in men's health and urology. You're going to want to hear this one if you're interested in testosterone, if you've been curious about the pros and cons of these weight loss injections, and we even got into ED at the end of the episode. But before we get into that interview, let's talk about a couple things real quick. It's not too late to take advantage of the free week of training with us. Several people have jumped into that within the last couple days, which is pretty exciting. digitalbarbell.com/free week. You don't have to put your credit card in. You don't have to tell us your mother's maiden name. Nothing like that. We're going to get you set up in the app that we coach all of our clients in, give you a flavor of, or give you a taste of our flavor of training. And one of us in the company is going to coach you through that entire week. So you'll get
and
to
then
see,
you're going to be hooked.
It's
That is true. That is a good point. It's not one of those things where you're like, sign up for a free week, give me your credit card number, and don't forget to cancel. Yeah, it's not like that at all. We're not. It's not. We're not setting out to trick you.
Yeah, we just need your social security number.
We just want to show you what Digital Barbell is all about.
Yeah, so take advantage of that. digitalbarbell.com/free week, and of course we'll put a link to that down below. Sponsor for the week is none other than the Home Depot. More saving, more doing. The Home Depot. I wish I could sing a little song. Well, no, we actually we don't go to Home Depot very often anymore because it's like
it's in another city.
Yeah, it's like 15-20 minutes away. Wow.
25.
But I sent out an email and we put a couple things in our Instagram story about this. But Blakely had this genius idea on Saturday as we're getting bit by mosquitoes around our little cowboy pool, which has been another podcast sponsor. If I
that we homemade ourselves.
Which is basically, if you don't know what a cowboy pool is, it's an 8-foot diameter galvanized steel stock tank that they use for livestock. They fill it with water and leave it out in the field, and the cows can go up and drink out of it whenever they want. They also double as a great little pool.
Yeah.
If you don't want to spend tens of thousands of dollars on a pool, you can get this thing for like $300 or $400. Get a pump actually for like $150. You go on YouTube, you see how to hook it all up.
Drill a hole in it, seal her up, and you got
Drop the hose in.
I mean, the benefit is like 2 summers ago, we had like the blow up pool for our god kids and that. And we didn't we were like emptying it and we were wanting to use it on the weekends and stuff when they weren't even here. But it's like you had to refill it with water. And we were going through a drought at that time. And I was just like, I felt like we're wasting all this water. The benefit of this cowboy pool is it has a filter. And so it's pumping water through and you can chlorinate it. So we're able to fill it up once, just like a regular pool, and maintain all summer long. We have a little cover for it. But anyway, I've been like trying to like figure out a way to have a little, not like a full deck around it or anything, but just like a ledge or something to be able to sit on at the level of the pool, because it's like waist height, I guess. So you can't really like sit around it and put your feet in or just, right now it's pretty cold still. So I just like want to put my feet in and everything. But so I pulled up this like bench to it. It was a little bit lower. I jerry rigged it with some like some stone blocks and got it to the height. And I was like, okay, I have the vision. Can you build this? And he drew a little sketch on a note card, and Sunday after church, we were going to Home Depot.
You know what? Since I have to edit this video in together with the interview, I'm gonna put a picture overlay right here on the screen of the finished deck.
It came out really good. One of our friends was like, "Okay, new Digital Barbell / deck making services." I think like the hard part is like we made a deck against a curved surface, so I was very impressed with what a good job you did and how it came out. And how you figured out how you were going to cut wood at a curve. I was like, I don't know how I was going to do it.
Trade secret. I can't share it. All right. So we'll put a link to how to build your own cowboy pool in the show notes for this episode.
Oh, the other thing though, I have been using this. I don't know. It just made me use the pool area more. And every day so far this week, I mean, we're on Wednesday here, Thursday. So I have gone in after my workout for like 2 minutes as like a cold plunge. I mean, it's not full of ice, but it's well water and it is darn cold.
It's probably in the 60s.
And I love it. It makes me feel like invigorated for the rest of the day.
Yeah. Plus like it's all the sweat off you from your workout.
Bonus. But highly recommend.
Nobody's going to want to come over and use our cowboy pool now. They know it's just full of sweat water.
It's got the filter.
Yeah, true that. Okay, there you go. And Home Depot sponsored the episode because that's where we went to buy the
Ooh,
wood. So there you go. There's
yeah.
the connection with that. All right, let's get into this episode. If you happen to be up in the Arlington area, at the end of the episode, Mike gives his contact information. If you're a man listening to this, or if you're a female listening to this and your husband is interested in men's health, he really prioritizes taking a holistic, teamwork based approach with his clients as he talks about. So stay tuned to the end so you can find his contact details. All right, let's get into the interview. All right, we have a special guest today. You guys buckle up. We've got Michael White, who is quite possibly Digital Barbell's strongest client, but he's also a PA in men's health and advanced cancer in the field of urology. So welcome to the podcast, Mike.
Thanks for having me, man.
Yeah, I'm excited about this. We're going to get into all kinds of stuff from testosterone to weight loss injections, building muscle, erectile dysfunction, all that fun stuff. But first, I want to get to know you a little bit. You told me recently that 4 years ago, you never thought you would be able to lift. You'd never be able to like do heavy deadlifts or heavy squats ever again. So tell me where you're at with that now. I'm dying to know.
Yeah, no. So, just to kind of give you background, I grew up athletically, football, basketball, baseball. I always kind of lifted weights, had an athletic build, I guess, in high school. So it was just kind of bred into me that way. You get into college, you still do your thing. I still lifted weights. I had a family, kind of reverted to, okay, I'll do this. And it just kind of falls by the wayside. So then I got back into lifting weights and thought I could do what I used to do. And that was a big mistake. And I remember, literally 4 years ago, being in a squat rack and thinking, oh, okay, I'm just going to throw 225 on here. I used to do repetitions of this with no problem. And I remember feeling a pop in my back. And at first it wasn't that big of a deal. And my wife was like, you really need to take it easy. She kept telling me, you need to go back into this slowly. You're rebuilding a body that you let go, for years. And I remember, having to go into surgery that next day and standing there for 7, 8 hours, and my back, it just was killing me. So I called one of my buddies who's a neurospine specialist. I was like, hey, I think I really might have messed something up. So we got an MRI. Sure enough, I herniated 2 discs. A lot of patients will say they blew their back out. That's essentially what it felt like. And I remember the progression of just pain and suffering that then occurred after that. I would say it was 6 months of, barely being able to get out of bed. I think it was a humbling too for me because I always see patients coming into our clinic, they're in, walkers, wheelchairs, you're like, that'll never be me. I was there. Jonathan, it was seriously a humbling experience. So yeah. I had to put weightlifting on a hiatus for almost a year. My neurospine specialist, he joked with me that he could get 2 nice vacations out of my back and that it would be a lifelong journey of surgery if I didn't straighten up, is what he called it. Yeah. So, I started doing physical therapy. I started learning new ways to, build my body back to what I could get to. And this was just a baseline. And I remember thinking then, I remember laying in bed one night talking with Amanda, and I was like, I'm never going to be able to squat or deadlift. And she's like, no, you're just not going to be able to do it the way you used to. And she's like, but if you train properly, you will. And she was actually a client of y'all's back then. And I remember thinking I would see her, get her iPad out and she would go through her stuff. And I was making up my own, workout, thinking I will never do anything of what she's doing. And so she told me one day, she's like, hey, just try a workout and see what you think, but go light. And I remember thinking, okay, this is the beginning. I don't know if I'm going to buy into this. Mm-hmm. But I remember, 1 week turned into a month, turned into 2 months. And I remember feeling, kind of back to my old self, where I felt like I kind of have control of things, that it wasn't an out of control, lower back pain every day type scenario, but it was definitely a lifestyle. It's not something that you just jump back into and say, okay, yeah, I'm going to do this, and in 6 weeks, I'm going to be great. I think that's the mindset we have, not only as Americans, but as just humans, is that, okay, if I do this, then I'm going to be here in 2 to 6 weeks. That's not the, you guys preach this all the time. It literally is a journey. It's a lifestyle. You've got to make those small changes that lead to big results. And that's kind of what happened. And I would say, I mean, what I was at when I was in high school, Amanda still, it frustrates me all the time. We just did our maxes, this past week. I was just really mad at myself for bench and squat. And she's like, you're not 18 years old again. Like, you've got to remember this, so definitely big changes in 4 years from not being able to literally do a body weighted squat to doing, over 400 pounds on squat and deadlift. I mean, that just kind of blew my mind. It still scares her sometimes when I put weight on. But it feels good to be able to do things semi to what I used to do.
It's fun, man. You guys are a pleasure to work with. So it's, yeah, we feel lucky to have you guys on our team. Let's get into the nuts and bolts here a little bit. What tell everybody kind of more. I gave you a little bit of intro there, but tell everybody what you really do on a day-to-day basis and who you help.
Right. So to kind of give background to, so I had a surgical background. I did cardiothoracic and transplant surgery before I went to PA school. So I ran a research lab in heart and lung transplant. Went to PA school, knew I wanted to do something surgical. And, the joke in urology is that you don't find urology finds you. No one goes into, PA med school, thinking I'm going to go into urology. That's just not
right.
And so when I was in college, PA school, my granddad was diagnosed with bladder cancer. And our family kind of had to deal with that. And I had to see the mismanagement of his cancer. And I remember thinking back then, what, if I ever get into really a field of medicine, I want to do something that I can help people. And that sounds very cheesy, but it truly was the way I felt. And so in PA school towards the end, I had a urologist that is now my mentor, brought me in. I did about a 3-month rotation with him. And I got to see kind of the buy-in with a patient, especially from a men's health standpoint, prostate cancer, renal cell, kidney cancer, the effect that you have on a patient's life. Not only just treating, but just kind of that overall, I call it like, we become a team. Mm-hmm. And then about 10 years ago, maybe 11 years ago, when we were doing a lot of robotic prostatectomies for prostate cancer, I had one patient tell me like 9 months after, I tell this story all the time, he came in upset, depressed, and he was like, you guys broke me. And I was like, what do you mean we broke you? And he was like, I mean, I can't get an erection. I leak on myself. So the men's health side of me, it's the switch turned on that. And I knew that I had to be a better clinician for the patients in terms of education. So then I went down a rabbit trail of men's health and, how I can change the perception, because it's not a question that was really asked to a lot of patients back then. We were just so set on let's treat BPH, let's treat cancer. And that was it. And men's health was just pushed to the wayside. Now, yes, you have the blue pill. That was, it's a multi-billion-dollar industry. But, it's most of those patients were going to their primary care doctor asking for a pill, and that was it. And there was, no other treatment option really given. And so I kind of took a subset of, okay, I want to really focus on men's health and how that ties into overall wellness for a male patient. Mm-hmm. And in doing that, to kind of give you background story history on this is kind of the way I ended up meeting my now wife. I would refer a lot of my male patients' spouses, partners that were female to a PA in Arlington, Texas. I didn't know who she was. I just knew she did female sexual health. So I would try to tee up, if you want to call that, the male patient. And then I would send the female over to this PA, and she would work on the sexual health for the female, which I wanted no part of. And so that's kind of how our relationship, if you want to call it, a working relationship, kind of developed. To me, it's an important part of, whether it's, male, female, you've got to have a buy-in from both parties. But male patients, in the past have been very, very shy, if you want to call it that. It's not even shy. It's more of we joke and call it a machismo thing where, I'm a man and, I'm not going to talk about this. That is that's slowly starting to break down. I think more men are coming in based on, education, whether it be on TV, on magazines, more people are, interacting, via social media.
Yeah.
It's opening up.
That's got to be exciting for you since that's kind of what you're passionate about.
It is. I mean, and so, so even back 9 years ago, the North American Sexual Medicine Society meetings, they were, very small meetings, and especially for an advanced practice provider like a PA or a nurse practitioner, there was nothing there for us.
Yeah.
Now we went to a meeting and we did a hands-on training this past year, and there were over 120 APPs alone at that meeting. And so, it has just drastically changed. I mean, it's skyrocketed in terms of number. So, that awareness is getting out to the patients.
Yeah. I think, with short form media out there being like the main source of information and entertainment for better or worse these days, I think it'll continue to get better. All right, let's talk about something I think everybody's mind goes to when they think about men's health, just because of the prevalence of it. But I think there's a lot of misunderstanding around it. Let's talk about testosterone for a minute. What does testosterone do for a man, and when, as far as age, does it start to decline, and why could that matter?
Sure. So, I mean, testosterone, it's a hormone, and there's if you want to call it a pathway between the hypothalamus, the pituitary, and the gonads. And you've got to kind of understand that cycle, because that cycle really makes a difference in terms of what's being turned on and what's being turned off. What it does for men, it increases muscle mass, cognition. It helps with cognition, meaning, mental clarity. A lot of men complain of brain fog later in the day. Bone density is something that's not talked about a lot of times when you're treating testosterone. This is what happens to, you can kind of liken this in terms of advanced prostate cancer. When you deprive someone of testosterone, the risk is you're decreasing the mineralization, or the thickness, if you want to call that, of the bone. And so when your testosterone levels decline, your bones become more brittle. That's the way I kind of, tell patients. Red blood cell production, erythropoiesis, the production, that's a big part of what testosterone does too, which can be a negative side effect too. And we can dive into that in a little bit in terms of, I call it, it's like changing your oil in your car. If you're giving yourself testosterone, you can thicken that blood. So there's a balance in that too. So anytime you're altering a hormone, you have to understand what the other side might happen, what you might change in the body as well. Sperm production, there's a balance in terms of the sperm production in a male patient. If your testosterone levels are at a healthy level, or if they're, super therapeutic, what are you doing to the body in terms of you're pushing that sperm level down? So this is a question all the time that I get, especially in like mid 20, early 30 guys that come in and they think that they just need to be on testosterone. Well, their wife might be undergoing IVF. They're having problems with, fertility. It's because their testosterone has been, treated, and they had no idea that their sperm count was zero because of this. And then the biggest thing I would say is sex drive, just overall energy as well. That's where most guys come in through that front door asking, hey, my energy levels or my sex drive is just, it's in the basement. And so you kind of have to talk through that in terms of, is this a testosterone thing, or is this a lifestyle thing?
Interesting. I think we're going to dive into that for sure. What would be the typical age? You mentioned, I was surprised to hear you say guys in their 20s and 30s going into these low T centers or whatever and getting therapeutic doses. What's kind of a common age for, the natural decline in testosterone that does happen?
Sure. So, I mean, kind of what the NIH and what some of the like Harvard Med School, I'll name one guy that if, your listeners really want to look at testosterone, kind of the, Bible of testosterone, is Dr. Morgenthaler at Harvard University. He's kind of the guy that, grandfather, if you will, in terms of testosterone treatment. That's kind of who I look at in terms of guidelines. And, also he kind of treats testosterone a little bit different than a lot of people would in terms of kind of the alterations of micro dosings or super therapeutic levels. But to answer the question in terms of when does that decline occur, usually about 40 years of age. What you start seeing is at 40 per year, as we age, you get about 1% to 2% drop in testosterone. Now, it's going to change too in terms of what your normal range is. A lot of 40-year-olds, as we know in America, are overweight. So obesity is going to affect that level. Estrogen, I tell patients all the time when they come in for a consult, and they just want, a joke. I'm like, you just want a jab. That's not what this is about. If we're going to do this and we're going to do this as a team, we need to understand kind of what your body and how it's going to respond. And then it's a two-part series. It's medication, but it's a lifestyle, kind of how you and Blakely, y'all preach too. It's important. You can't just have one. You can't just lift weights. This is when I started training with y'all, I was like, okay, well, I'll just lift weights and my diet will be garbage. And my wife was like, that's not how this works. And she let me, she is an angel compared to me because she let me do my own thing. So it was kind of one of those things, you fall on your own sword and see how this works for yourself. And even when we were training initially, you're like, hey man, you really need to tighten this up, or hey, you need to do better. I'm talking to patients and I'm not doing what I'm telling patients to do. And you saw that and got onto me in a nice way, so I had to change the perception too. And I'm still doing that. It's still, this, like I said, it's a journey. I still want the things that I shouldn't be eating or, whatnot.
You mean you're human after all? I think it's good for everybody to hear, like, people feel like they're the only people who struggle with some of these things. But guys, if you're listening to this, you are human, you are broken, you are fallen. We all struggle with the same things. It's okay. We can get through this together. Sidebar on that, but yes. Do you think it's harmful or helpful for men to go get their testosterone tested?
I think it's an eye opener. I think it is helpful in the right setting. I call them pop-up T centers. We've got to be careful there. So like we just talked about, like you said, what's the average age of decline? 40, right? But, you've got to look at it too. And I kind of had my eye open listening to a podcast about 1.5, 2 years ago, where, you always get this perception of, and I actually helped the Low T Center out in Fort Worth, try to manage some stuff on the weekends because they were having some issues with control in terms of, what was a baseline for like PSA, let's say. How does that affect your PSA? Which we could get into a whole, different discussion. But, we tried to kind of tighten the bolts, if you will, on how they were treating these patients. And, these testosterone mills where they're seeing 40 patients a day, you got to be very, very careful in terms of how you're doing that and in terms of what you're testing. So, I tell guys all the time, look, if you feel like, your energy levels are low, sure, go get tested, but understand what that test means and make sure when you have a healthcare provider review your labs that they know what they know and they know what they don't know. Right. And I think that's, I joked with you earlier, in terms of a phone a friend, I've always got somebody that I can call, whether it be someone on the West Coast, East Coast, someone in my clinic. If there's something I don't know, I tell a patient, hey, look, I don't know this, but I have a friend that does, and I'll get back to you. And so I think that's important. So you look at those labs and you see kind of where that patient's baseline is. And a lot of patients come in really, really mad when you go through their labs because they're like, well, I don't feel good, but your testosterone level does not show with your symptoms. So let's talk about the health side. Let's talk about the lifestyle side.
That's a great transition into, okay, so once we know if we're going to get a therapeutic dose of testosterone, that's only one side of the equation. Let's talk about the main lifestyle factors that do affect our testosterone production and what we can actually take control of, even if we are at the place where we're not feeling good because our T levels are low.
Sure. So, I think one of the things in terms of obesity, you look at it's, epidemic level. You just walk around on a normal basis and you look at, and a lot of people are like, oh, you're just skinny. It's not that we're skinny, we're actually healthy in terms of, oh, you're eating that. It's almost like one of those things. If you take a meal prepped lunch to work, you get chastised about that. Right. By the average person. It's a sad transition we've gone to. But, I tell patients too that come in that are 40, 50, 60 pounds overweight. I'm like, look, I can give you testosterone, but there's a problem with this because the fat cells that you have that are secreting estrogen in your body are going to change that profile treatment. And so you have to tell a patient, look, if we start doing testosterone, I call it TRT, testosterone replacement therapy. And there's many different ways, and I'll kind of jump into that real quick in terms of how you can treat someone that has low T, okay, call it that, or hypogonadism is the medical term. We can do the kind of the hallmark testosterone cypionate, enanthiate type injections. You can do gels, which, have been on the market for quite a while. Androgel is one of the ones that has been used in the past. You can do under the arm, in the nose. There's Testo. You can use pill form. The biggest one now, and the one that we kind of prescribe, is Kysotrex. And there's a lot of reasons to use the pill form versus the injection form. Again, we can dive into that if we have time. You can do pellet therapy. Pellet therapy is a nice type of therapy for patients that are traveling, that have a very, very busy schedule. They can't do an injection, or, they're literally on a plane all the time with their work. You usually put a pellet underneath, sub-Q, and they come back in about every 3 to 4 months, depending upon their levels. So those are kind of the therapies. But the management of that too is the buy-in that when you do testosterone therapy, you have to manage the numbers, and you have to look at the numbers on a pretty regular basis. Too many times I see patients come in that are being managed maybe by a primary care provider, and their labs are only being managed every year. So they're looking at their labs once a year. So I have, and it sounds funny, but I have an agreement with patients. If I'm going to manage your testosterone, you're going to sign this agreement. Like, it's like signing, when you buy a car, hey, this is your health. This is no different. And so I tell them, I'm like, look, if we start you on a therapy, I'm going to get labs in 6 to 8 weeks. And then I'm going to get labs in 3 to 4 months. And we're going to stay on a regular basis for at least 2 years. Every 3 to 4 months, I'm going to look at these labs and see kind of how things are changing, because you'd be surprised at how many times patients, especially male patients, are the worst type of patients in terms of staying consistent. Consistency is key. You guys say this all the time. It's the same thing in medicine. So, it's like, okay, where do you want to be? You always ask that question. And where do you want to be in a year? And I tell patients that all the time too, is, okay, I can manage this, but at the end of the day, 50% of this is me treating you. 50% of it is you being a patient, staying consistent on treatment. So again, those different treatment modalities, you can kind of also look at the patient and say, this patient really needs this, because I know they're not going to do things the right way. It's no different than coming up with like a nutrition strategy for somebody. At the end of the day, we know somebody's got to be in a calorie deficit to lose weight, but we can do that in a number of different ways that fit their lifestyle. So it sounds no different than that. Definitely. Let me say one thing too, just so we kind of get this, on the table, and this has kind of been one of those things. It's been kind of the elephant in the room for testosterone therapy. A lot of people think testosterone causes prostate cancer. That's not true. A lot of people think too, and they've had this misconception that testosterone causes strokes and heart attacks. Also not true. Now you have to weigh that too. There's a balance again. Remember, we talked about the whole hormone balance. In patients that have prostate cancer, it is the fuel for the fire. So if you're dumping testosterone in the body, then it can fuel that growth of that prostate cancer cell, let's say. So if you have a patient that has a history of prostate cancer, family history, you've got to be very careful in terms of your management. That's one of the first questions I always ask a guy that's 40 years old, or older. Do they have a history? The other thing is the heart attack, the stroke. There's a trial called the Traverse trial that was released in 2023. And what they looked at is they did placebo and testosterone management in patients that had mild to moderate cardiac risk. So patients that had, high cholesterol, maybe they've had a, cerebral vascular accident, have they had any kind of history? Do they have atherosclerosis, defined, atherosclerosis? And those patients versus placebo actually had a cardioprotective effect. So it actually helped. Because, like we talked about, it builds muscle. Testosterone does build muscle, but it also protects the heart. So, I just want to make sure that we talk about that, and we can talk about that later, but it is important that misconception kind of be squashed in terms of, what we're treating, how we're treating, and who we're treating.
Yeah. It reminds me of the kind of the misconception around protein is bad for your kidneys. Well, no, if you have kidney disease, then we might need to limit the amount of protein you have, but it's not causing kidney disease. Let's go back to the lifestyle factors. We talked about being overweight being a main contributor to decreased testosterone. What else is there, and what can we do about it?
Yeah, in terms of, you say the lifestyle in terms of what we're eating or how we're training?
Let's talk about the link to muscle mass, to resistance training, and to proper nutrition.
Yeah. So, I always, and I've said to you before, it's like you just said, protein, protein, protein. We're not getting enough protein. Now, again, if you have kidney disease or you have other medical conditions, you've got to balance that out. And I say, talk to your primary care provider about it. But, like you're doing right now, drinking water, water and protein, those are the two biggest things, the two biggest balances that I even to this day, have a hard time getting. I'm like just trying to get my body weight in grams of protein in a day, and it's tough. But it's the fuel that feeds the muscle. So, I tell patients, look, I can't give you this magic poke or this magic pill. That's not going to fix this. You can't, just sit on the couch. Mm-hmm. So you've got to pair that with a healthy lifestyle of, and you guys walk all the time. We've kind of changed the way we've done stuff over the last almost 75 days to where, get out. It's important to get sun. I tell patients that all the time. They just kind of look at me. I'm like, no, you need vitamin D in your life. You need these things in your life. They're small little building blocks. And so making sure you're eating vegetables, I sound like my mom back when I was a kid. Eat your vegetables, drink your water. But it's like one of those things. Yes, grilled chicken gets very old after a while, but you can, mix things up. And I think that, you and Blakely have, y'all, what do you call it? You have your air fryer.
The laser printer.
Yeah. So, it's like you can make things fun. And that's where I think too, once you get into this healthy lifestyle, it's hard, but it's also very rewarding as a clinician to see the patients that have started out where, they weren't able to walk a mile. That sounds ridiculous. You'd be surprised. And these are people that are in their 30s and their 40s. And you talk to them about downloading the MyFitnessPal app. So what I do is, it's almost like a challenge to the patient. I'm like, hey, I'll do this, but when you come back, you got to have buy-in like I talked about. I want to see on your phone, your MyFitnessPal, and I want to see at least 2 weeks logged, of food. Now, I do a lot of other stuff in clinic, but to me, that's the most rewarding in terms of seeing that change. And you almost see like a light bulb turn on. That's kind of what happened for me with you guys, because I kind of left, I used to eat whatever I wanted when I was in high school, and our metabolism catches up with us. Right. So, it's nice to be able to see I had the same light switch turn on, just like these patients, in terms of, oh my, yeah, what Jonathan was saying actually makes sense. And so seeing that healthy lifestyle, telling patients, look, you need to get X amount, 80 to 100 ounces of water. I can't do that. Oh, you can. It just depends on if you're willing to. There's a difference between, ability to do something and willingness to do something.
Right. Yeah. There's a difference between willingness to do something and deciding you are going to do something.
Yeah. I tell patients too, which, I can't tell you how many little, I call them pearls I've taken from y'all, in terms of, when you pick something up, like if I'm on the road and I'm going to Houston or I'm going to East Texas, you're in a gas station, you flip that over and you look at the protein content, and you always talk about multiplying that. And is this a good source of protein, or is this just a scam in terms of labeling? Our Federal Drug and, Food Administration has done a really good job and let people slide in terms of what's healthy and what's not. Yeah. And I think that that's also kind of an education. I've told patients, hey, log on, you have Facebook or Instagram, log on to Digital Barbell, just listen to their stuff. It's free in terms of the resources that they give you. Look at what they're talking about and see if that can kind of be, implemented into your daily lifestyle. Because again, it's not just, you can't just take a medicine and think that it's a magic bullet, that it's going to cure everything. That's, again, the misconception. You have to have that paired with, healthy lifestyle. Also, the other thing that still have a problem with is sleep and getting the proper amount of sleep. I'll let you kind of talk on that. I mean, you tell me what the good range is.
I mean, if somebody's getting 7 hours of sleep on average, I'm extremely excited. If they're getting 8 hours of sleep per night, they're extremely excited because they're seeing the benefits of getting that sleep. But I understand it's hard, from the outside looking in to just, say get 7, 8 hours of sleep, because I realize it's complicated when people have kids and there's all the responsibilities of license and stuff like that. But I think that if somebody would just commit to doing it for 2 to 3 weeks in a row and they see the difference that they feel and all the downstream effects that it has, then it becomes less of an issue to get it done, because it's now self-motivating to keep doing because you feel so stinking good.
Yeah. I mean, and another piece that we haven't talked about in terms of lifestyle modification is alcohol. That's one of those things. It's a touchy subject with a lot of people too, in terms of accountability. Um, you know, so, we've been doing this hard 75 journey is what I'll call it. It's not always been so fun. Again, Amanda's she's the yin, I'm the yang on this. And so it's like,
What day are you on?
I'm on day 61.
Oh, wow. You're in the home stretch.
Yeah. I mean, I've got no problem admitting I love bourbon. That's one of those things. I don't do it to get drunk. I enjoy the taste of it, and it's a balance. And I tell patients, look, you always talk about, if you're going to do this, then just maybe find one day, and don't overindulge, because all that buildup you've done through the week, all that hard work that you've put in, and then you just crash on the Friday, Saturday, Sunday. You just negated all that hard work that you put in through the week, all that getting up at 5 a.m., changing things, that lifestyle modification. I tell patients too, I'm like, look, if you have a Ferrari, okay, you're not going to put, 85 octane in a Ferrari. So why would you put trash in? You're going to get trash out. And, it's the same thing with alcohol, which is going to have to be, when we come off this hard 75, I'm going to have accountability with myself of, hey, remember what you said about maybe 1-2 days a week, and also minimal amounts.
Yeah, it's way undervalued, the effect that it has on people's recovery, the calories in it, the poor decision making afterwards. I think a lot more people could be more consistent with their workouts by getting up in the morning to do them like you guys do, but that's really hard to do if you wake up with a hangover from, having 3 or 4 cocktails the night before.
Definitely. I mean, it is. Just it's science, right? So
right. It's been proven over and over again.
definitely.
I think this is a good transition. We've been talking a lot about, sustainability, quick fixes, that kind of stuff. Why don't we dig into the topic of the day? Just talking about, whatever Oprah's talking about these days. Let's talk about the weight loss injections. There's so many things we could talk about this. Why don't you talk about how these weight loss injections work a little bit? Because I think there's probably a lot of people out there that don't even understand really what's going on with them. And then we'll dig into kind of like, what's a practical application for these?
Yeah. So, weight loss, I don't know how many billions of dollars a year in just America alone. You're talking about
all the billions.
Oh yeah. It's crazy. Because again, quick fix, nothing's a quick fix. It's like I joke with one of my buddy who has done this. I'm like, you're just putting duct tape on something. That duct tape's only going to hang on for so long. Right. And so, we talk about a balance too, in terms of, they go to, an aesthetic center, they go to a pop-up shop in a strip mall, and they're promised, oh, you'll lose weight. Well, you'll lose weight, but there's also a negative effect. And what is that balance? So, the big thing now is semaglutides. And again, I'm still educating myself. The Huberman Lab, I don't know if you've looked at, that guy is brilliant. He's a neuroscientist from Stanford University. And he's got an hour-and-a-half podcast on just this topic alone and what it does. So semaglutides, again, I'm no expert in this, but I can tell you, there are natural occurring hormones, just like testosterone that we talked about. Same thing with insulin and some of the other hormones in terms of what they do, in terms of how we process foods. So what we've done as humans, we're trying to find ways to trick our body. And this is what we're doing with a GLP-1. A GLP-1, agonist, let's say, natural occurring hormone, what it does is it acts almost like the pancreas in the body. If you increase insulin, I joke, but it's like you grab, cells and you're pulling that food. So increase satiety, or increase fullness. But when you're over, increasing this amount, so you're, again, thinking like, you're turning the wheels extra fast. So not only is your pancreas working, but now you're putting a medication into your body that is making, an overproduction, let's say, of insulin, in terms of what it's going to, yes, you will feel full, but what are you doing to the pancreas now? There are such things as pancreas burnout. It's called pancreatitis. And so, I see this a lot too when I was at one of the trauma centers I worked at for 16 years. That is a horrible thing. And you've got to look at the lasting effects of what it does to your body. And nobody's talking about that side of it. They're just worried about the then and now. And, I can shed 20 pounds, I can shed 30 pounds, I can shed 40 pounds. But how do you maintain that? Because eventually you got to come off that medication. I mean, you can't stay on the medicine forever. And the way it was developed was for type 2 diabetics, okay, trying to get a better control in terms of where that insulin measurement is. So if you or I took a GLP-1 agonist, and our bodies are already at a healthy stage, right? Okay, so you look at your insulin level kind of at a fasting level, and let's say it's, your sugar level is at like 98. Well, say you throw on this medication, and so you're going to decrease that. Okay. So now, you feel full and you're not eating, but what you got to worry about is in that weight loss, now you have muscle loss because now you're not training because maybe you don't have that energy. Yeah. If you're a healthy individual per se, or let's say that you've lost 30 pounds and now you need to start making those lifestyle modifications. Are you willing to do that? Because when you come off the medicine, you've got to worry about where's that upswing, what's going to happen on the back end of this. And too many times I see friends, colleagues that have lost all this weight, and within a year, guess what? I'm back to, where I used to be. I think the Atkins diet was one of those things back in the day where everybody would buy all the bars, hit ketoacidosis. They'd be grumpy for several days. And then, 3 months later, they're back to their jolly self, but they're back to their jolly self because they've gained all this weight back because they didn't maintain a healthy diet. So when you start these things, you need to also talk to your, whoever's giving this to you, your provider, about also incorporating a diet. And if that healthcare provider is not willing to sit down and take the time and talk about a healthy diet, you probably need to go somewhere else that is going to talk about that, because it's important that you pair both of those things. Because when you start losing muscle, like, with testosterone, the same thing, you got to worry about cardioprotective effects, bone effects. What's it doing? Demineralization of bone. What are you doing in terms of your blood formation? So those things have not really been talked about. And, I told you before we got on here, I'm really worried about what this looks like in 5 years from now. I remember when I could, watch TV at 10 o'clock and watch The Price is Right. And they would have all these, if you have this and this problem, call this number for
class action lawsuit.
Oh yeah. So, I mean, we're already, I think, kind of going down that path, because we're not pairing the understanding that you just can't take a medicine for the rest of your life to fix a problem.
I think a lot of, like you said, a lot of these medicines were developed for diabetics. So probably a lot of them have been tested more over the long term, but, in the context of helping somebody manage their blood sugar, not necessarily if somebody, loses 150 pounds, and how long that's going to take and how, the amount of the drug they were exposed to make that happen. So it is going to be interesting to see what happens. So like the main things, let's say we were advising somebody who is starting to take this, what are the main things we want them to focus on? You mentioned continuing to build muscle. I know you already know the answer to this question, as do I, but just in case somebody's confused about what it takes to build muscle, as you lose weight, what are the most important things to focus on?
Yeah, I think protein is one of the big things. Is if you're not going to eat much, then please focus on the protein intake that you're taking in, and also the water intake. I think it's important that, you look at what you are going to put in, make sure you're getting as much protein as you possibly can within a healthy range. Because so many people are just eating, let's say, one, maybe 1.5 meal a day. And if they're not getting, say that you're eating nothing but salad, then you're not getting that protein content that your body is craving. It craves that. And so it's your body's going to take from somewhere. If you're not putting it in, it's going to deprive the body of something. And that means it's going to start breaking down muscle. So I think that's big. And then also, Amanda does a good job of a balance between, green leafy vegetables, broccoli, cauliflower, whatever it might be, but also pairing that, don't just go run out and get fast food and thinking that's I'm only going to eat one meal. That fast food meal is going to be my meal. You look at what the breakdown of that is, and you're not going to get the protein that your body, needs.
Yeah. I want to emphasize that for people because I feel like I've had several conversations with people lately about the importance of protein. And they kind of say to themselves like, yeah, I'd probably be making more progress in the gym if I ate more protein, but it's hard. Or, I'm not really seeing the results of my workout. I know I should probably eat more protein. And the point that you made is exactly right. If you are doing that damage to your muscles in the gym, lifting weights, pushing hard, and you're not putting the amino acids in that are the building blocks of muscle, you quite simply can't expect to continue to get stronger and have muscle. Your body will attack the existing muscle you have for energy. So it's not that you would be doing better if you ate enough protein. Your results would be completely different, and you would just you'd be on a different level if you did it. So it really, really is important. I know it, we often come across as like protein, like all we want to talk about is eat more protein, but it really is important. So I hope people, understand whether you're trying to lose weight, you're just trying to increase your performance or your body composition with, there's two things you can focus on: what you do in the gym and what you do in the kitchen. And if you center what you're doing in the kitchen around eating enough protein along with all the other whole foods, like boom, you're on your way. Little side commercial there for protein.
Well, it's not that hard either, right? I mean, if you, it's habits, right? It's forming good habits. And I tell patients all the time, you don't have to don't dive into this where you're doing this 7 days a week. Let's try to take 3 of 7. Okay. And then I say, okay, we can push it to 4 and 5 days. So how y'all do with your training? Like, you look at, okay, do you want to start out doing 3 days a week training, 5 days a week training? You got to give your body rest too.
Right.
But I tell them, I'm like, you'd be surprised at the amount of time on a Sunday, after we come home from church and we do our stuff. And then we take about an hour and a half to 2 hours in terms of meal prep, getting chicken out, getting whatever, red meat, fish, whatever you might be doing. Chicken's the easiest because it stays longer, let's say, in the refrigerator. And so, everybody has their part, whether, prep, grill, laser printing, whatever you're going to do. But, and then also the cost. What people don't understand either is look at the overall cost in terms of management. If you're not budgeting, take the time, do it for a month. Look at the cost that you're saving, not only your body health, but also your wallet. Yeah. And, I tell patients that all the time too. It's like, yeah, you think going by and getting that fast food is the best fix, but in the long run, at the end of the month, what have you done? The deficits to your wallet and the deficits to your body.
We just finished doing our taxes here at the last minute. And, one of the things you have to enter is the amount you spent on medical expenses for the year. And I had this accident, this past summer, and that was very expensive. But outside of that, we don't spend money going to the doctor. We don't have any prescriptions that we need to fill. But you know what? We do spend a lot of money on quality food at the grocery store and not at restaurants. That's the trade-off for us. So, yeah, I get what you're saying. All right, let's leave weight loss injections alone for a minute and move on to erectile dysfunction, or ED. Seems like whether we're on YouTube or I'm scrolling Instagram or what's popping up on Hulu, there's just like advertisements for ED products you can buy everywhere. Why don't we tell everybody what even classifies as ED to start with?
Yeah. So, the misconception is that, ED is, you just can't get an erection. No, it's the defined medical term is to be able to sustain a, erection that is satisfactory for intercourse. So what does that mean for you or for whoever? That changes, it's a variance. So, most of the time, it's the inability to get erection based on blood flow from a pathophysiological standpoint, meaning the blood flow in, blood flow out. And so you have to take a balance of, when your patient comes in, what medications they're on, what other comorbid conditions they have, meaning hypertension, diabetes, high cholesterol, have they had, cardiovascular accident? Have they had a stroke? Have they had a heart attack? Have they had a quadruple bypass? Are they on depression medications that can lead to, ED? You have to look at too the psychogenic. So, the mental side of this. Is there a mental block in this? You're starting to see a change too in terms of ED affecting younger generations. Before, this was just a thing that you would think, okay, a 50, 60, 70-year-old guy is dealing with, but that's not the case so much. Now you've got guys that are in their 20s, 30s, and 40s, that they're really dealing with ED. But is it something that they've caused themselves? So is this medicine induced? Is this psychologically induced? Or is this a comorbid condition that is causing this? I think one of the things too is vaping, tobacco usage, alcohol usage, things that are in our society that are considered kind of a norm, have really affected the amount of blood flow that we're dealing with. Drinking increases fat cell production, increases estrogen release, increases all the cascade of stuff we talked about before with testosterone, but it also can affect blood flow in. And so I tell guys, and I won't get on this kick, this can be for another day, but what you put in your mind, okay, in terms of maybe something you're watching on, the internet, and what is reality, that's the psychogenic side. So I have to have a real conversation when a guy comes in and he's 25 years old and he's telling me he has ED. What have you been doing, on the other side of this? It's an
self-induced.
Yeah, it really is. And you, again, ownership. You have to take ownership. It's not just a quick fix. They think they come in and I can give them a pill and that's going to fix it. That's not always the case. In the patient that has arterial or vascular blood flow, I call it, vascular nicking, if you will. There are certain things you can do to identify and diagnose this. You can do Doppler scans, meaning you can take an ultrasound probe, you can look at the tissue of the corporal body of the penile tissue to see what the blood flow is. You'd be surprised that about 70% of these patients that think that it's a blood flow issue, it's really not. Maybe it's something else. Like, for instance, I tell patients, they laugh, but I call it the triad of penile death, where if you're taking a hypertensive medication, a blood pressure medicine, high cholesterol medication, and a diabetic medication, you could be the healthiest guy in the world, but those medicines alone are going to knock out the ability to have an erection. So you kind of have to tell patients, I'm like, look, you got to have a healthier lifestyle. Try to focus on this. Again, that's the foundation, right? And everything's built on that. You wouldn't build your house on sand. You got to have a nice concrete foundation. So, I tell them, look, some of this stuff can be reversed, and again, there's a lot of misconceptions too on, PRP, so plasma-rich protein. You'll get a shot and it fixes X, Y, and Z, or falciform injections for girth, and that they think that that's going to fix something, or they get a testosterone shot that's going to fix ED, which we didn't really talk about, but it goes hand in hand, but it doesn't fix erectile dysfunction. Again, it's a multi-billion-dollar industry in terms of the pill form. Our society focuses so much on take a pill, take a pill, take a pill. It's easy, quick fix. In some patients, yeah, it's great. And it does work and it is necessary. But in others, you can tell them, look, we can start you on this, or if we can at least alter some of the lifestyle things, then maybe we get back to a point where you're not having to take these medications or shots or whatever. I think that, it's a slippery slope. We joke about treatment options of pills, pokes, procedures. That's kind of what we talk about in our clinic. There are other options. Again, it's like training. You take your options based on the patient alone. So I think, like that first conversation I have, and a lot of people say too, they're like, well, you're in good shape. Like, you don't have this problem. Well, how do you know? You don't know me. You don't know what I'm dealing with. So let's focus on you, okay, and unpackage the problems to see maybe if we can't get you off this medicine, I can put you on this other medicine, but it's not a shell game, and we can't keep playing that for the rest of our lives. Mm-hmm. And so you have to have that ownership, that buy-in with the patient too. What form of ED do you really have? Go ahead.
So let's say somebody has kind of already decided that they have ED when they come to see you. I think that's probably pretty common.
Yeah.
How receptive are people to hearing that really the best thing you can do for them is encourage them to make lifestyle change when they really came to you for a pill?
Yeah. I mean, you get patients that are turned off. But I think that if you approach somebody in I said a teamwork approach. I mean, you and Blakely do it all the time. You're not like pounding on a podium, you must lose weight. You do it from a different approach. So if you approach the patient with a caring attitude and look, we'll go at this as a team. I'll get you where you want to be. But you've got to make changes yourself. And I think if you impart that wisdom to a patient, and I also, now they might throw away all this information that I give them as soon as they walk out the door. That's on them, right? Just like you guys, y'all get online, talk about all the things that people need to hear, but are we really willing as humans to take all this in and process it, implement it into our daily living? So I talk about the pathophysiological side. So what is the, hormone side? What is the blood flow side? And then what is the actual anatomy side of this? Because again, there's a multitude of problems that could have occurred, you had your accident on your face. Well, that same thing happens, with guys on a farm.
Yeah.
Maybe there's been an injury. That's a different type of ED, so I have to take that into account too. But I try to impart a little bit of wisdom with the patient. If we're talking for 25, 30 minutes, when you're doing that initial consult, making sure that they understand their anatomy, because you'd be really surprised at how many times clinicians go into a room and they just think, because I know this, you should know this.
Yeah.
And I tell people all the time, when the plumber comes to my house, I tell the plumber, talk to me like you would talk to your dad, because I don't know plumbing, but so you got like, it's human plumbing. So I have to understand what the patient does and doesn't know. And so, I, put out a lot of information, a lot of educational information, probably too much sometimes, where patients leave with a stack of papers. I'm like, that's your homework. I'll see you in 6 weeks. I'll give you a pill, but pill's not the fix. So, and not everybody needs a pill. I mean, seriously, it's like one of those deals, and not everybody needs a poke. It's not a quick fix either. And I think that you'll get, I'd say probably 10% of the patients that come in our door, they probably leave frustrated with me because they didn't get what they were told. And they're probably going to go down the street, and there's a pop-up clinic. I know there is one. I deal with the repercussions and the side effects of all this stuff. Yeah. I mean, because you look at it in terms of overall treatment, in terms of what that's doing to the patient. And so they're going to find their quick fix. We're human. But, I try my best to educate the patient on these quick fixes have their side effects. So you need to understand when you leave here, if you're frustrated with me and you go somewhere else, what to expect, what you're going to pay out, and what you're going to pay out from a health standpoint. So
it's kind of like a combination of giving people a little bit of what they want and a little bit of what they need too. Like, I'm going to go ahead and give you the prescription that you think you came in here for too, but like, here's a way that you can modify your lifestyle so you can eventually get off of this pill. And I imagine people react to that in different ways.
Oh, definitely. I mean, and two, I think I talk about if I can do something from a homeopathic standpoint, I will. I always say, less medicine is best medicine to patients, because it is important. I mean, And when my parents lived in Europe, and I would go to like the little village doctor, a lot of times he would go through these like really weird treatments. So, I'd go and like talk to him more and more about, how they were doing things from a European standpoint, and I think there's a lot we can learn as Americans from, Asian treatment options, European treatment options. The way we do it's not always the best way. And I tell people too, and it's kind of almost like a little trick, if you will, like L-citrulline. Okay. You guys use L-citrulline?
No, but I've researched it before.
So, it acts as a vasodilator, right? And so we talked about early on the ED side, in terms of there's a vasodilation blood flow issue. So I tell patients, okay, if you kind of just use this small amount into your daily lifestyle. Now, I'm not going to do this on a guy who's had a quadruple bypass and I'm going to cause a stroke, but semi-healthy guy, you start just kind of altering these things and giving them some information that's not just going down the hall and picking up Viagra, Cialis, Levitra, Stendra. Some of the other options, you'd be surprised at 25, 30% of these patients that are coming back and they're like, wow, that really did make a difference. And then you've got somewhere, you gained a little bit of traction. So now you can start talking about other things besides just swallowing a pill.
And even if it was placebo, you still got the intended effect out of it.
Yeah, 100%.
I think it's actually in some pre-workouts now that I think about it.
Yeah, it is.
It must be a really small dose though.
So I use a scoop of it a day.
Yeah.
And cool. And I do it in my pre-workout. So
there you go.
And I try to tell patients too, and this sounds crazy, but I had a neuropsychopharmacologist in college that, I don't agree with everything he said, but he did say one thing in terms of, and it doesn't work, so don't take this to the bank. For me, I'm able to do it because I'm not working in, let's say, endocrinology per se, where I'm not going to take insulin. But a lot of the medicines that I give patients, I'll take and see the side effects. Amanda thinks I'm crazy, but I want to see.
She's probably right.
Yeah, I want to see the dry mouth, the dry eyes, and a lot of providers would not tell you they do this. But the same thing in terms of some of these men's health type things, what are the side effects of headache? Because they have their side effects in terms of if you're going to put a medication on, you got to worry about how that affects a patient's other medications. And people don't talk about that too, in terms of headaches and, changing color, flushness, X, Y, and Z, what you're eating or drinking with that. So
interesting. Yeah. I was thinking about that when I was having all that dental work done after my accident, because the dentist was really good about telling me what was about to happen whenever he was doing stuff. He said, you're going to feel a little bit of a poke here and then a little bit of a burn. I'm like, how do you know? Like, did you do this to yourself so that you could know what this feels like? Because he was like, spookily accurate with the way that it felt.
Oh yeah. Yep.
Did he just like remove one of his teeth just so he could know what this was going to feel like?
Man, you'd be surprised during medical training what we have to do or in terms of like the training a lot of times is on yourself or your partner. I had I'll call it a clinical partner. She lives in Houston actually. And, we had to do like all of our, what we call auscultations where you listen to chest and lung but then also like looking at the other side effect of like, foods and medications and other things in terms of, so it's pretty funny, but it happens and nobody talks about it, but it's out there. I promise.
I never thought about it until this conversation.
Yeah. Yeah.
Well, we covered a lot of stuff here. I hope that, the people listening feel a little bit more clear about, the role of testosterone, what it's like to be treated, when it might be appropriate, what we can do for ourselves besides getting treatment for it. A little bit about the sustainability of weight loss injections and what we can do to maintain muscle mass if we go down that road. And, I would just say, there's a big, what's the word I'm looking for? Stigma around talking about ED probably. So just not being afraid to consult a professional if you feel like you're dealing with that and being willing to accept the fact that a lot of it might come down to lifestyle, just like everything else we talked about. Is there anything else you want to leave people with today?
I mean, for men, I think the stigma is changing slowly where you're getting more guys that are coming out and talking opening up about it, because I knew I grew up in a house in a generation too. I mean, I'm not that old. My kids think I'm old, but my dad's generation, though, they will not talk about this.
Mm-hmm.
And I think it's important to talk about your overall health, because there is that mental health side of it, in terms of, talking to somebody like a primary care provider. We try to get into, the discussion and the buy-in with primary care and cardiology and pulmonary as an overall approach to health. So,
Mm-hmm.
If the primary care team, if they can't treat you, there are subspecialists, whether it's, urology, they've got men's health, women's health clinics. But men need to open up about the problems they're dealing with. I mean, I downplay a lot of times. There are treatments, and I'm not saying that I don't want to treat patients at all based on their clinical conditions.
Right.
But also there's the buy-in to, if you're going to talk about this, you buy into what you're doing as well. And I think that's important, that a clinician says this. And I tell patients all the time too, if I'm not willing to do it, how can I expect you to do it? So a lot of times if a patient goes into medical office and they're asking about health and wellness, and you're not taking care of yourself, same thing with you and Blakely. Why would I train with you guys if y'all aren't, practicing what you preach? And, I try my best to make sure that not only my patients, that my kids know this. It's important that you take an overall buy-in to your overall health for long-term viability.
Yeah, man. Yeah, I can completely identify with that. Well, let's just say somebody's up in the Arlington area and they want to come find you. How do they find you?
Definitely. Yeah. So Urology Partners in North Texas. We've got 8 locations. Our men's health clinic is at the main office off of Cooper. It's in South Arlington off of I-20. Feel free, reach out. Men's health clinic, it's Dr. Andrew's son, PA Michael White, and PA Troy Houston. We will always be more than happy to do whatever we can do for the patients. And, it's our pleasure as providers. We love doing this stuff on a daily basis. This is what I get up every morning for. I enjoy it. It's a gift for me, I think. Work sometimes hard, but we're gifted with the fact that people are, trusting us with their health. So, I don't take that light. So
that's awesome, man. You undersold how hard you work. I know your travel schedule, flying around the country speaking, and the hours you put in. So I really appreciate your time, man. I'll be checking your workout later today.
All right, man. Thank you.
Thanks for your time.
All right, bud.